transferred to the phone. You can see that there is some transfer in progress, and I'm hoping this will transfer. Yeah. So you can see that it has been transferred. If I move it down, you can also hear it on the heart and lung filter. So you've got about 9 seconds of capture, and we will want to upload this. So I will like to share this. There are say 2 records. I'll process. There was an earlier record as well. I'll process this as well. So now this has also been sent to the electronic health record. Now, so the ECG cable, fundamentally, this is the ECG cable, which can be attached here. So once you attach the ECG cable, then you have your 4 limb leads. You have the 4 brackets on the hands and legs. You just put them, just simple hand, no chest leads here. And then you attach this cable and you run the ECG. So I'll avoid that right now unless you want to see it. Do you want to see it?
No. Only limb leads or chest leads as well. Are taking only the without chest leads, only limb leads.
Yes. So the chest leads will be in the 12-channel continuous monitoring will be here, which I will show you. Yeah. So here it is just a 3-lead 6-channel. One is Earth. So 3 leads and 6-channel output will be there. Now that we have done with this, now this is the job on this for one individual is over. Now I will share my screen again. I will share my screen again. And if you can see, we'll come back to this. Can you see my screen now?
Yes.
Okay, so this is a blank record that we had created for this patient. Now, since the data has been uploaded, I will refresh this. Once I refresh this, you will find that the natural language processing, one is the risk stratification. He has been high risk, and this is the NLP summarization of the patient, which the doctor will be very interested in. It says the initial assessment suggests pre-existing cardiovascular disease that may need further evaluation and risk and treatment. The patient is predicted to be at high risk. You will also see that the date is mentioned here, and in the date, you have also got all of the readings. Here you got the 241 postprandial, 98.2, 98, 83, all of that, and you observation reading as well. So if you can hear it, if you want to be looking at it, you can hear it from your phone, you can hear it from the record also. So this is as far as the first thing is concerned. This is an application where we can run reports on how many patients were done, say, in the month of July. This is just a test database. So I will submit this. You will find this is a report that can be generated along with all of that. Then there are the next year 2 will also be there. I will come to this, but let me just, in the meantime, come back here and take some questions. So this was the first year where the individual, your health worker has gone into the communities, created records, screened the patient which is available to you. The doctor is not yet come into play. The doctor comes into play when we push the medium and high risk individuals through the reports. It is available with their phone numbers. They can be called based on a schedule, or these people can then go and report into the primary healthcare center. So first is the spokes within communities, then we draw them into the PHC, and then what happens at the PHC is what I will show you next, but I'll stop here to take questions.
Now, this is brilliant, but what was the initial objectives of your project? What was the idea, the main vision to start with? Is just to recruit high-risk patients to a more specialized advisory centers? Is that the idea? Or because of lack of doctors going outside, you want to other technician to help doctor to facilitate this work?
Fantastic question, Dr. Saab. So first thing in India, so we have implemented this in India, and the problems in India are there are about 65% of the population which resides in villages and is dependent on the public healthcare system. Now, the doctors, there are more than 1 million modern medicine doctors which reside in cities, in urban. And then you see you are
It's a
allowing
discrepancy
access.
between both. Yes.
Yeah, so then you have camps. What we have done here is through these sub centers or community centers or through frontline health workers. The government of India is now sort of focusing on NCD screening, so non-communicable data screening, health screening, communicable data screening now, communicable disease screening, vaccination in enforcing vaccinations, etc. Post COVID. So now they want to know what is the health status of their communities in rural tribal areas as well as the urban poor. So this was the objective of this entire solution, which is then taken forward by the public-private partners or healthcare providers. So we have created this solution first to be able to go into the communities. So this is filling the gap between hospitals to communities. And
Yes.
now, once you go into communities, you can get individual health picture as well as community health picture in terms of non-communicable diseases percentages, and that's really where the dashboards and the big data analytics comes in terms of what is the prevalence of a particular disease, given that we are capturing all of that, and then go it to the second tier. So I hope I've answered your question, Dr. Hilal.
Yeah. Yeah. Correctly. Is that your instruments? Sometimes one might say probably the results are not accurate. Is there is any sort of validation or
Yeah. So again, a great question. So this device has been continuously improving over the last 6 years. We have actually fielded this device. So we have number one ISO 13485, which is the basic minimum for medical devices. Then we have a BIS certification, which is so the standards, Bureau of Indian Standards. It has that certification. It has gone through ethics committee approval, and now it also has CDSCO approval, which is the Indian medical device certification body for any government program. So it has got CDSCO approval as well. So we've got all of that, ethics committee approval, certifications, and then deployment and scale. Coming to the accuracy part, this is a screening device and a go, no go device. So its accuracy will not exceed 95%. So it will be between 85 to 95%, but it is a go, no go device. And the other device, this is a diagnostic device where ethics committee approval was done at Apollo Hospitals, Apollo Research Innovations, where the head of cardiology, Dr. PC Rath, was the principal investigator. And this was found to be performing equivalent to hospital care equipment. So we have the ethics committee approval and the reports. Also, it is ISO 13485 certified. So that is the, I hope I've answered that. Yeah.
Oh, thank you. The third question is that this technology have been used outside India or only in India? Any other countries are using this technology?
We had done some pilots in Nigeria because we wanted to validate the color of the skin, basically Asian as well as African. So there was a pilot which was done in Nigeria, and the results were okay. They were done through one of the hospitals in Lagos, but we did not follow it up because from a business perspective, there was some currency risk and all of that. We did not follow it up after the pilot. And that was done in 2018. And the results were, again, being a screening device or a go-no-go device, the results, though it is called a go-no-go device, we find that it is pretty accurate.
Okay, thank you.
Put as Omron and what have you. So now, I will go back and share my phone now, and then we'll move on to tier 2. Before we move on to tier 2, and I will show you the deployed device, but suffice it to say, I'll explain the ports to you. This is the device. Even the cap doubles up as a display. So you open the cap, this becomes your stand. So your display becomes your phone, and otherwise it is the cap. And this has, let me explain this to you. This has got the power switch here. This is a cable. This is your 15-pin which the ECG commercially off-the-shelf ECG cables would be attaching to this. No special requirement. This is for the this is push fit, color coded push fit kind of connectors, which anybody can do. But since this is ECG and intermediate care equipment, we would